Welcome back. For this lecture, we're going to continue our discussion on pharmacology for the advanced level provider and drill down a little deeper into pharmacokinetics and pharmacodynamics. If you remember, when we discussed pharmacology at the basic level, pharmacology has several principles that help determine what the impact of the medication has on the body and what impact the body has on the specific medication. In fact, we identified two specific terms there. Pharmacokinetics is the action of the body on a medication, and pharmacodynamics is the action of the medication on the body. Through the routes of administration, or once we administer a medication, it goes through several processes, and each of these processes are modified depending on the type of medication we've given, the route, the metabolic state of the patient, and what the intended effects or side effects may be. Those processes include things like absorption, or how the body takes up the medication, distribution, how the body moves the medication to its intended target, what form of transformation occurs, whether it's through metabolism or other forms of biotransformation that occur to the medication once it's administered, and then elimination, how the body gets rid of the medication's byproducts or metabolites. Let's look a little bit deeper into pharmacodynamics. What you see on the screen here is a basic image that describes some of the types of medications that we use and some of the ways in which we use them. On the left-hand side of your screen is an example of acetylcholine. And while we don't really administer acetylcholine, it serves as a good example to see how we use pharmacology to drive actions within the body. So you can see at the synapse here, ACH is being formed and then secreted. Acetylcholine is secreted into the synaptic cleft near the cell, and at the cell wall there are receptor sites for acetylcholine to bind to and some action to occur, whether it be muscle contraction or secretion or enhanced utilization of other chemicals. Perhaps it's the facilitation of active transport of molecules into or out of the cell, or electrolytes into and out of the cell. That acetylcholine binds to that receptor site, the action takes place, and then typically an enzyme comes through and helps remove that neurotransmitter from the receptor site and out of the way of the synaptic cleft and moves it in to be further metabolized later and then ultimately eliminated. For EMS and pharmacology, we look at two types of drugs that will work in a similar fashion. Agonist medications are designed to bind to that receptor site and create a simulated event, if you will, or a stimulation effect on that receptor site to encourage the cell to engage in that action again, synthetically. So an agonist drug binds to the receptor sites and enhances cellular activity or encourages the naturally occurring process to occur either more frequently or more vigorously. One example of a type of medication that we use commonly in EMS is epinephrine. Epinephrine binds to the receptor site. It's an agonist medication and stimulates the sympathetic nervous system, or what's commonly referred to as a sympathomimetic. And we'll look more at other sympathomimetics in subsequent lectures. The other type of medications that we can use are antagonist drugs. Antagonist drugs inhibit the binding of chemicals to a receptor site. A common medication that we use in EMS that is a competitive antagonist is naloxone or Narcan. Narcan blocks the opiate receptor sites from being activated and often is used as a reversal agent, if you will, for opiate overdoses or when there's too much of that occurring chemical affecting the respiratory system specifically. Other types of medications we may give may not directly act on the receptor site itself. So for example, and I've got a zoomed in image here of the same one we looked at previously with acetylcholine, we may also use medications that help facilitate the movement or the sweeping effect, if you will, of those neurotransmitters out of that synaptic cleft. I mentioned the enzyme that's in place for acetylcholine that breaks it down and moves it out of the synaptic cleft. That enzyme is called acetylcholinesterase. That ASE indicates that it's an enzyme. We may also give medications that inhibit that enzyme, so acetylcholinesterase inhibitors, or what are commonly referred to as ACE inhibitors, that allow the acetylcholine to bind to that receptor site longer. So it's not a direct agonist or a direct antagonist, but we can drive the effects at the cellular level based on the presence or absence of that individual chemical. Agonist and antagonist medications both will have a dose-response curve. And the dose-response curve is important for you to understand while you're administering medications, because not only does it determine the amount of medication you need to give to reach that therapeutic window, the window of which we describe the patient is experiencing the intended effects of medication, but how long they exist within that therapeutic window is also driven by factors including age and metabolic rate, and may determine the need for us to redose that medication at a given time. So if you look at the dose response curve, you can see that at a certain point, once we reach the therapeutic level, then the patient is now experiencing the intended effects that we would expect them to see. Ideally, and if I extend this a little bit further here to the side, once we reach that therapeutic window, the rate of metabolism and how fast the patient metabolizes the medication will slowly start to bring their concentration of medication out of the therapeutic window, in which time we may need to consider redosing that medication. This is where we often look at repeat dosing times for pain management or other medications. As they come out of that peak therapeutic range, metabolism, their way that their body is eliminating and metabolizing that chemical, is exceeding the amount of medication to reach that therapeutic window. So we'll need to reassess that patient to make sure that we can redose and maintain them in that therapeutic range. Some of the factors that are going to affect how a patient responds to a medication: one, the choice of medication. Oftentimes on an ambulance, as an advanced level provider, you may have more than one choice of medication to treat a specific ailment. For example, you may have, for pain medication, you may have an opiate pain management like morphine or fentanyl to manage a patient's pain, but you may also have non-opiate pain relievers such as Toradol. You may need to choose the best medication for that patient, as not all presentations are met by the same medication. In other words, one pain medication isn't appropriate to manage all types of patient pain. It also can be affected by the dose. If you overload the dose for the patient, you'll push them past the therapeutic window and into the toxic window, in which case you can have more deleterious side effects. Route of administration can also affect the uptake rate and may determine how long the patient has access to that medication from a metabolic sense. The timing, how frequently you give the medication, can also impact the manner of administration, and of course you're monitoring the patient in need for redelivery of medication once they've fallen out of that therapeutic index. Other factors that can affect the response to medication: the patient's age. Patients on extreme ends of the spectrum, when extremely young patients or elderly patients, may react significantly differently than patients in the middle of the age range. Particularly with older patients, they tend to have decreased metabolic rate, so smaller doses may be needed, and they may have prolonged effects as they can't metabolize those medications as quickly. Weight may also play a role. You'll notice that some of your medications are going to be weight-based, and that's because a larger mass patient may have a faster metabolic rate for those medications specifically, and it may take more medication to reach the therapeutic window or maintain that therapeutic level. Environmental factors, and this includes temperature particularly. When patients are hypothermic, medications are often not metabolized correctly or fully and can ultimately not even be effective. And so when we talk later about management of hypothermic patients, we'll start to withhold medications until we reach a certain core body temperature. And then you have things like genetic factors, things like pregnancy and other psychosocial factors that also can have a significant impact for these patients. Pregnancy is its own set of complications with medications. We want to make sure that when we deliver medications to a pregnant or a gravid patient, that we're aware of the pregnancy category risk for these patients. Risk categories for pregnancy and medications are generally noted by a letter, class A, B, C, D, or X. Class A pregnancy medications have found that controlled studies fail to demonstrate any risk to the fetus in the first trimester, while on the other end, category X medications, as studies in animals or humans, have demonstrated fetal abnormalities, and there is evidence of fetal risk based on human experience, or both, and risk of use of the long-term drug in pregnant women clearly outweighs any possible benefit. So you need to take into consideration the level of risk if you're administering medications to a pregnant patient. This can be convoluted and sometimes an ethical question in EMS, particularly when you look at medications like Class C medications, where they have revealed the opportunity for some adverse effect, but if the patient is left untreated, neither the patient nor the fetus will survive. These are common complications, and rather not common complications, but these are real complications that do arise in medicine. And it's important that you understand where your policy is on this and your med control physician has drawn those lines. If you find yourself in this situation, it's often helpful to reach out for online medical control and help get a second opinion for these patients specifically. As far as pharmacokinetics are concerned, this is the section of medication that looks at things like onset, and this is related to the absorption or distribution, the peak of the medication performance, and the duration or how long that lasts, and this revolves back to that therapeutic window that we had discussed previously. It also looks at how medications move through the body, and this is oftentimes determined by chemical properties, physical properties, and patient factors. One of the key things to remember is that if we're giving a patient a medication, particularly through the parenteral route, where we're going to rely heavily on circulation, you want to make sure that the patient has adequate circulation, that the medication can reach the intended area. So you may consider using an intravenous medication as opposed to an intramuscular or subcutaneous or intranasal medication in a patient who is more circulatory compromised. Medications have to move through protective barriers as well to also be effective. Some of those barriers include things like the blood-brain barrier, the blood-placenta barrier, which is oftentimes how pregnancy medications are classified, and the blood-testicular barrier. Blood passes freely through the capillaries in the kidney, the thyroid, the pancreas, the lungs, and the peritoneum. But if we have medications that are targeting specifically those areas, we want to make sure that they either intended to cross the blood-brain or blood-placental barrier, and what are those intended effects or side effects or adverse effects may be. Lipophilic medications can be sequestered in fat of an obese person. So this is one part of consideration when you look at medication administration. Someone who has a high concentration of lipid cells or is significantly obese, those lipophilic medications or medications that are tending to hold up in lipid tissue, they may release more slowly, and this may cause a prolongation of the effects. Volume of distribution is a term that describes to the extent to which the medication will spread throughout the body. Medications that have a lower volume of distribution have higher levels present in the plasma and are not diffused as quickly. Most medications are going to undergo transformation in the liver. The P450 system is the main metabolic pathway in which most medications will undergo. The kidneys, the lungs, the GI tract, and other tissues can also cause some forms of biotransformation. And biotransformation makes those medications easier to eliminate and secrete, either through urinary secretion or fecal secretion. It's also worth noting that there are some medications that will go through a first order or second order of metabolism before they are effective. And this is less common in emergency medications that we use, but can be common in patient medications that they take at home. And that means they take a bioinactive form of the medication. And as it undergoes a first pass metabolism, it then becomes an active metabolite that is utilized by the body before being metabolized again subsequently and then eliminated.